Good afternoon, everyone. It is 12:30, so we're going to go ahead and get started. It looks like we have a good group on. So first thing I'm going to do today is the first of our webinar series for the Southwest Stroke Committee. This is an annual webinar series that we do, and our wonderful volunteers come together and come up with some really great topics for you guys. So today we're going to be talking about door in, door out times, the next big benchmark, with Dr. Rob Alunday. Before we get started, though, I just have to present a quick disclaimer from the American Heart Association, just letting you know that the recommendations and opinions presented by our speaker today may not represent the official position of the American Heart Association, and these materials are for educational purposes only and do not constitute an endorsement or instruction by AHA. We do not endorse any products. Okay, and with that, I am going to introduce Dr. Alunday. So our speaker today is Dr. Rob Alunday. He is a professor in the Department of Neurosurgery and Emergency Medicine and Medical Director of Neuroscience, ICU at the University of New Mexico, Albuquerque. Dr. Alunday is the director of the University of New Mexico's Neuroscience Intensive Care Unit, providing modern neurocritical care. His enthusiasm and thorough patient care, along with combined training in emergency medicine and neurocritical care, ensures that his patients receive the best care possible as quickly as possible. His friendly professional bedside manner makes him a favorite of his patients and their families. In order to provide continuity and shared resources, Dr. Alunday has dual faculty status and shares his time in the Department of Neurosurgery and Department of Emergency Medicine. He will also be working with the department to provide emergency stroke care for patients in rural hospitals through telemedicine technology. Dr. Alunday is a volunteer supporting the American Heart Association, American Stroke Association in many capacities, and is currently serving as the chair of the SouthWest Stroke Education Committee. I will now turn the presentation over to Dr. Alunday. Thank you, Dr. Alunday.
Hello, can you guys hear me okay? Just
yes,
want to make sure I'm up. Okay, great. And the lecture's on the screen, correct?
Correct.
Wonderful. Thank you everybody so much for being here. It's exciting to be talking to you guys about what I think is the next big benchmark. Door in, door out times. We'll be referring to this as DIDO times, just because that's more fun. Thank you so much for the introduction. I probably should update that a little bit. A couple of things have changed in there, but no big deal. I am at the University of New Mexico, and I think it is actually really important to say that I am an emergency physician and a neurointensivist. I did my residency in emergency medicine and fellowship in neurocritical care, and I split my time between both worlds. In fact, last night I did an emergency medicine shift, and I'll be there again tonight, and then next week I will be in the ICU. So I get to see these patients from the moment they hit our doors to the time they get over at least the worst part of their illness. So I love taking care of these patients and love to share information about that. Okay, so financial disclosures, I have none. But I wanted to define the door in, door out time. And so this is just a schematic that I drew up here on this PowerPoint. And essentially the care of the stroke patient starts off with them on the scene having their stroke. They call 911. EMS departs, they get to the scene, that's that red box. They do their assessment and they package the patient up and they start leaving that scene and arriving at usually a primary stroke center, but they could also be going, well, in terms of DIDO, they go to the primary stroke center. Once they hit the primary stroke center, they get there is a time between arrival and CT scan. And then from the CT scan, they get their, they have to have that decision and then administration of alteplase or tenecteplase in a lot of circumstances. And also whether or not they get their CT angiogram also happens here too. Once the diagnosis is made of a large vessel occlusion, which we won't go into that because I'm sure everybody on this phone call already knows and is not living under a rock. But then they make the transfer request to the Comprehensive Stroke Center. Once that request is in, an ambulance has to be called to come pick up the patient. They arrive, they get sign out on that patient, and they package that patient up, and then they leave. And then there's some more time for, oh man, I did this wrong. I apologize. The door in, door out time does not go all the way to arrival at the Comprehensive Stroke Center. It only goes to the end of that purple block when they leave that primary stroke center. I hope that made sense. I am post-night, so if words are coming out kind of funny, I do apologize. So why is the dido time so important? And I think it has to do with the fact that, first of all, there are disparities in the capabilities at different hospitals. Not every hospital has the ability to do a thrombectomy. Not every hospital has neurosurgeons. Not every hospital has neurocritical care. Not every hospital has stroke docs for that matter. There are designations put out by American Heart Association, JCO, and the like, and they all pretty much look like this and in this order. There's the acute stroke ready hospitals. These hospitals are able to give alteplase in their emergency department. Then there's the primary stroke centers. These primary stroke centers are able to give alteplase, give tenecteplase. They could keep a lot of the strokes that they do take in, but they don't have all the capabilities of the other centers that are next in line. The thrombectomy capable stroke centers are able to do thrombectomies. They could do, someone comes in with a large vessel occlusion, they have the rooms, the personnel, the physicians that are able to take the catheters, bring them up to the brain and pull that clot out. Then there's the comprehensive stroke centers that can not only do the thrombectomies, but they also have all the other care that surrounds stroke as well. So if there's large complications, comprehensive stroke centers can take care of that. They have dedicated neuro ICUs. They have neurosurgeons that are available to do decompressive craniectomies in case there's a lot of swelling, or if a ICH happens, and if it warrants going to the operating room and removing that large hematoma, they could do that at a comprehensive stroke center. So when patients arrive at the primary stroke center, I think it's important to remember that time is brain, and brain cells, they don't stop dying once you hit the primary stroke center. You could give alteplase, which is great to try to reduce the disability, but it's not as good as a thrombectomy if that patient has that big enough clot. So getting that patient from the arrival at that primary stroke center to the time out of that hospital can make a big difference here. This is just a slide that I like to use just to demonstrate the importance of improved outcomes with earlier administration of thrombolytics. On the top right there, you can see that the odds of having a good outcome are better the earlier you give the alteplase. The farther out you go, the chances of a good outcome become less. And on the bottom right there, it shows mortality as your chances of dying are less likely if you are given alteplase early on versus later. This next slide is very similar, but this one is in regards to thrombectomies. So again, you're on the left side is time, on the left side over here, you have a higher odds of having a better outcome if you have your thrombectomy early. This study by McTaggart in 2018, these graphs show that you have better NIH stroke scales and modified Rankins those are associated with smaller door in, door out times in patients that have less than perfect thrombectomies. So I don't know if you can see here, the TICI 01, 2A, and 2Bs. These are not, well, 0 means they couldn't get any of the clot, and you still have a large amount of clot burden and low perfusion. 2Bs is pretty close. 2Cs are almost perfect, and a 3 is a perfect thrombectomy. They took all the clot out and you restored all the perfusion. So if you had less than perfect, the shorter your door in, door out time was, the better your NIH stroke scale was, the better your modified Rankin was. So they all improved. And it's also really important to show that there are when there's transfer delays, that can also be a limiting factor to even getting the thrombectomy. New Mexico is a big state, and we get transfers from all over the state. And sometimes by the time the patient makes it to us and we do the repeat scans, we see that too much territory of the brain has then died, and which really changes that risk-benefit ratio of doing a thrombectomy. And if too much of the brain has already become infarcted, then it's not beneficial for the patient for us to do that thrombectomy. Why do we do benchmarks? So pretty much because they work. When a large body comes out and says that we need to be aiming for this, people listen. We in general need goals. And when we hit those goals, it looks really good. We feel great when we do that. And when we don't, we feel a little shameful, and we don't want to feel bad. These goals that are set for us can help push us to do better. Also there is public reporting that is associated with all these kinds of benchmarks too, which again adds to some of that pressure for us to do better. And I like this slide because it demonstrates that natural tendency for us to delay treatments. I don't know about you guys, but I'm a huge procrastinator. I tend to get my lectures done in the middle of the night before the lectures. I'm definitely guilty of this tendency to delay everything until the last moment. And this data right here is from the original NINDS trial. And if you're not familiar with that trial had 2 arms. There was an arm where they gave alteplase at 90 minutes and another one where they gave it at 180 minutes from the stroke onset of the last known well. And you could see this huge number of patients that got it right here, right at that end, instead of more spread out over here. And even when they were given in less than 180 minutes, there was still a larger proportion of patients given at the very last minute, rather than a more even distribution there. So AHA came out with their target stroke campaign back in 2009, 2010. And this was a really cool study published in 2014 that showed that when they put this out, and the target stroke campaign, in case you're not aware, was the set of goals and best practices to reach those goals in administering alteplase in a timely fashion. When they put those out, overall in this country, we had an improvement in door to needle time. This is the percent of patients that were given alteplase in less than 60 minutes. And it went from 20 to 30%. If you could see my cursor there. And then the target stroke campaign came out and people said, oh, we need to start doing better. And slowly but surely, everybody did start to do better with that. Here's another very similar slide, but this one's got a little bit more data. This slide includes door to needle times of less than 45 minutes. And it showed here that also improved, and that's the triangles down here. That improved here, And in 2014, they had the, it says target stroke phase 1, but should say phase 2 here. And they incorporated a 45-minute goal. And when they did that, there was another little inflection point here to improve our door-to-needle times to even that goal. On the right side of the screen here, we could see that in-hospital mortality improved. Everything pretty much got better as far as outcomes goes. And this slide is a little bit different because it shows, instead of the door-to-needle at 60 and at 30, sorry, 60 and 45, this one shows door-to-needle times of less than 30 minutes. And that was a inflection point over here. So I think it's important to know that DIDO times are already being collected by TJC. It's part of the information that the data that they have us enter in. And just so you see that, it's right here, this STKOP1D, STKOP1G. But what's that benchmark? Oh, I see there are some questions in the chat. Oh, no, sorry. Yes. If you have questions in the chat, please feel free to ask. So what is the benchmark, DIDO? And actually, there are no benchmarks just yet. But I'm arguing that there will be one, and it won't be too long before it comes out yet. Now, I'm not on staff on the AHA, so I don't get to make that decision, so I'm not privy to when and if that will come out. But I think it's important to know that there are clues here. Joint Commission, they do say in 2013, Brain Attack Coalition recommended that stroke transfers occur within 2 hours. They also mentioned here a study in 2019 that a group was able to do DIDO times of 86 minutes during working hours, and during working hours, they could get it in an hour, and overall 86 minutes. So those are just some numbers that they put out there in their Joint Commission National Quality Measures Manual, published 2021. So they mention the times, they just don't specifically say we want people to hit these certain time goals. And there is precedent. AHA has been recommending DIDO times when it comes to their mission lifetime STEMI. So referring hospital, oops, there we go. And for STEMIs, it's door in, door out times of less than 45 minutes is what they are asking people to do. So less than 45 minutes in 75% or more of patients, and actually less than 30 minutes in 25% or more of patients. And there are some people that are already putting out numbers. So, just Googling DIDO times and what that benchmark is, I found that in Louisiana, they're collecting data and setting goals of, in this case, 90 minutes is what they said. And let's see. So I think this is a little bit of a clue to what we can expect here. So DIDO times early on in 2008, 9, 10, 11, 12, we see numbers like 76 minutes, 71, and a downtrend. And then Mission Lifeline STEMI, 2012, 2019, that DIDO time kind of stabilized out right around 45 minutes. So is that really the fastest median time that we can expect? Maybe. And I think it correlates with what they've been asking for and probably what centers are able to do. This is the Western States Task Force. So a little bit farther west than the SouthWest branch that I'm in. They've actually published this door in, door out best practices, and they actually said less than 90 minutes in more than 50% of patients being transferred for stroke. They put that out there as what they think we should be doing. So is there a formula? What can we do if you know, like the initial Target Stroke campaign, they gave out some best practices to go along with the goals that they were setting. So the next few slides, pretty much the rest of the talk is going to be data from different studies and what they did to improve the door in, door out time. So we could see what kind of practices that different centers are doing to improve this time. So this risk assessment of door in, door out processes at primary stroke centers for patients with acute stroke requiring transfer. And this study used a FMECA method. I had no idea what that was, but it's really an engineering method used in high-risk industries such as aerospace and nuclear power. And the FMECA, or from Mecca, I guess, help counter most organizations' common temptations to focus on process solutions for most evident and visible features, which may not be exactly the same. So this study by Hull et al., they found that reasons for having poor times or failure to perform an elbow scale. They had a lack of recognition of acute strokes. They had failure to start the tele stroke evaluation and failure with arranging appropriate transfer. Those would be the big causes of delays for them. And I think a lot of that makes a lot of sense. If you're not going to perform for them, the elbow scale is what determined who got a CTA. So if they didn't do that elbow scale, the patient would just get their non-con. And once they realized that the patient had a bigger stroke, then they would have to go back to the CT scanner, adding more time. The lack of recognition of acute stroke, that's when patients show up to triage and don't come in via ambulance, or if the paramedics didn't know that it was an acute stroke, those patients would go to a regular bed, and then someone would have to figure out that they're having a stroke and then start the process. And failure to start the tele stroke evaluation, that's either by the primary stroke center, that hospital's ED physician not initiating it, or the telemedicine stroke, the tele stroke doc being too busy on the other side, on the other line. Those were reasons for some delays and failure to arrange transfer. Say the transfer center line is too busy. That could be a mess. Here's another study. This one is by Amir Hassan, who's on the same SouthWest Stroke Committee as I am. In this study, they were using artificial intelligence via a program called VizAI to help find patients with large vessel occlusions at the primary stroke centers. And Dr. Hassan, being at the comprehensive stroke center, would be able to get access and get alerted when the artificial intelligence suspected a large vessel occlusion. So he would hear the ding on his phone, pull it up, scroll to those images, and be able to make things move faster. So this is right out of that paper that he had. And so looks like they were able to reduce times from 171 minutes down to 105 minutes for Dido times. This paper by Ng, deconstruction of inter-hospital transfer workflow for large vessel occlusions. An Australian study, they had 86 patients in 2015 and 2016, 3 primary stroke centers transferring to 1 comprehensive stroke center. And they analyzed the transfers that were specific to the thrombectomies, and they broke down everything and did a logistic regression looking for the associations with prolonged dido times. And so they found here that the largest time interval in that dido time was CT scan to transfer request. They found that dido times were different at differing primary stroke centers. So some places were better at it than other places. Times were shortened if the crew, the EMS crew that dropped off the patient at the primary stroke center was also the same one to transfer them to the, that should say CSC, transfer to the comprehensive stroke center. And they also found that during working hours, the dido time was shorter. So this is just that demonstrating that there's this large time between the CT scan to the retrieval request, requesting that transfer. So out of all of those delays, they decided that, or they concluded that extending the on-site stroke team presence was going to be helpful. Getting the stroke neurologists that were at their centers to be present in the hospital when those patients were actually coming in. So maybe not so much at 6 a.m., but more towards the 6 p.m. side of things. Having streamlined and unified protocols may reduce some process inefficiencies that you'd see from one hospital to the other. And just in general, if you have things that are the same every place, the same every time, people get better at that. Having that same ambulance crew that dropped them off, keep them there until the elbow's been excluded. If the elbow is found to be present, tell that ambulance crew to take that patient back up and send them over to the comprehensive center. And they also suggested that they initiate transfers based on accepted criteria rather than trying to play phone tag with the with the comprehensive center. So this study, they want to improve the primary stroke center processes, so reduce that time. Then enlisting the ambulance crew to remain at the primary stroke center until definitive transfer decision. So you can see how the door in, door out time is shrinking. Then initiate transfer based on automatic acceptance. So you can see how that, when we're cutting the fat with each one of those recommendations and how we can improve our door in, door out time. This study by McTaggart had 70 patients at Brown, transferred in from 14 different primary stroke centers. And these patients, just so you know, for this study or at this comprehensive center, accepted these patients directly to the angio suite, which is different than at least what our center does. And what they looked at was adherence to their primary stroke center protocols. So if there was good adherence to the protocols, 22 patients versus poor adherence. And that's how they separated out these groups and they compared the two groups. It's not the best, it's not a randomized trial on looking at two different protocols, but it is the best that they could do with the retrospective analysis here. So just so you know what their protocol was, they determined that if the patient was LAMS positive, which is, in case you're not familiar, LAMS is a pre-hospital stroke severity scale. If it stands for LA Motor Scale. If it was a positive result, and a result of 4 or greater means that the patient is more likely to have a large vessel occlusion. So for these guys at Brown, if those patients came in with that LAMS score greater than 4, or I should say at the PSCs of Brown, if those places found this LAMS score of greater than 4, then they would go through all the rest of this, which is their physician at the PSC would call the comprehensive center on arrival prior to imaging, which is, I think, novel. The comprehensive stroke center's critical care transport would be dispatched based on that phone call. CTAs performed at the time of the non-contrasted CT scans. So that way you don't waste that time leaving the non-con CT, going to a room, and then having to come back again. Images were sent over to the Comprehensive Stroke Center immediately, and all patients with confirmed elbows did get directly transported to the comprehensive centers, to the angio suite of those comprehensive stroke centers. And what they found when they looked at these two groups, the Dido times for full adherence was 64 minutes and 104.5 minutes if you didn't follow the protocol. And this was statistically significant. This is the same study. Onset to PSC, door was the same, but poor adherence to the protocol meant delays everywhere else. Door to alteplase, door to puncture, reperfusion, door in, door out time, all of those things were worse if you didn't follow the protocol. Also of note, the modified Rankins of 0 to 2 were higher in patients that had full adherence. So, very small study. Take this for what you will, which shouldn't be too much, but it did correlate with outcomes did correlate with better adherence to the protocol / smaller Dido times. So again, this fun little diagram here, if you improve the outside hospital processes and to improve time to decision, you get a big reduction. Door in, door out times and transportation times in two telestroke networks. This one is at MUSC, so South Carolina. There was 2 comprehensive stroke centers that accepted patients from 26 spoke hospitals. And they did a retrospective look at 85 patients from March of 2017 to December of 2017. And this is what they started with. Just another graph of door in, door out, and what makes that up. And what I think is interesting in this case and their protocols is that the CTA came after alteplase administration. And the CTA was not performed at all sites. That's really important information to know. So essentially at the primary stroke centers in this study, they would get their non-con CT first, decide to get TPA. So they would come off the table, give the TPA, and then figure out if they wanted to do the CTA. Some of those centers also just didn't perform CTAs at all. I don't know how many of you guys work at centers like that, but it does. I know at least in 2015, we were having to deal with that at most places in the state of New Mexico. It's definitely gotten a lot better since then, but it is a real problem. So the results of the study, most delays occurred during the period between alteplase administration and the door out. So they could give the alteplase quickly, but all the new decisions of do they get a CTA, who's getting transferred, that stuff was super slow. Improving the total time from obtaining the CTA at the spoke center, at the spoke sites to interpreting the imaging would result in improving the Dido time. So that's the, there can be a lot of delays if you get an image and radiology is not reading it right away. So improving that process is something that they needed to do. So their proposed solutions were to obtain a CTA upfront in patients who may be candidates for thrombectomy, similar to one of the other studies that we just talked about. LAM's positive, get that CTA. Performing telestroke consultation while in the CT scanner to decide on who needs to get a CTA without delay. That's another way that you could potentially do that. And we talked about LAM's criteria already. Some places don't even worry about Lamb's criteria to determine CTA eligibility. They just do it on all the patients that come in as a potential stroke. They get the non-con followed immediately by the CT angiogram. Philip Troy and all, door in, door out time is 60 minutes. This is kind of cool. This is the same group in Australia that we were talking about before. They documented their continual process improvements over the course of 3 years. And they wanted to find out what was associated with improved IDO times. And I think it's really cool to see that they were able to get to 59 minutes. And the way they did that was having the neurologist on site. That was associated with better times. Clinical trials were also helpful. And drip and go, that same EMS crew from inbound was the same EMS crew to outbound at the primary stroke center. This one is a retrospective analysis identifying potential factors that contribute to DIDO times at 3 primary stroke centers in Chicago, 191 patients in this study, and associated delays at the primary stroke centers. This is interesting. It starts off with CTA was a delay in their DIDO times. And I think that one's a little funny. It's sending the patient to the scanner twice, is kind of like what we talked about. So if you don't have a protocol on who gets CTAs, then you're going to have to spend more time thinking and making decisions rather than go, 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 go. Intubations, that's an obvious one. Patients that walk in, that can be a common delay too, versus the paramedics calling ahead and saying, we think this patient has a potential stroke. That gets everybody ready to go. If the patient just shows up at the door, getting all the people that need to be taking care of that patient downstairs quickly can be an issue if you don't have a protocol set up for that. Shorter DIDO times were associated with alteplase administration. And this one was interesting. Transfer ambulance request was initiated by the primary stroke center. So their list of potential best practices: obtain an ELVO scale early in the pre-hospital setting if possible. That sets you up for figuring out who definitely needs that CTA ahead of and makes that decision super easy for you once the patient shows up. Allow triage personnel to call stroke alerts. That was kind of huge for us when we made that decision. We gave our nurses up front and our APPs up front in triage that ability to call a stroke alert, and that triggered neurology to come downstairs, that triggered us in the main part of the emergency department to run over to CT scan and assess these patients right away, rather than being roomed first and getting a new set of vitals and waiting for us to see the patient. Imaging, they say obtain that CTA upfront with the non-contrasted CT scan. I don't know if you're seeing a pattern here. And they say either all stroke alerts or the ELVO screen positive patients. Send the images immediately to the comprehensive stroke center and get that interpretation of the CTA fast, potentially through AI. Neurology personnel on site would be best. Even better if that neurology personnel was a stroke neurologist, and performing telestroke consultation while in the CT scanner. You see a lot of the same things are starting to pop up because a lot of places are finding the same problems and same potential solutions. So in general, so that was a lot of the in general stuff, and summary list of potential practices continued. Interfacility communication. So maybe we should initiate transfers based on accepted criteria without waiting for a comprehensive stroke center approval of that transfer. That one's, I know, is going to be difficult, especially, here at UNM when we have a lot of problems with boarding, a lot of extra patients in the emergency department just waiting in the waiting room for too long, not getting beds. That's a hard sell at a lot of places, to just auto accept without talking to somebody. But it is a potential way to get patients transferred faster. We could expedite handoffs, physicians and nurses. If we just got that patient on to the ambulance and started driving and then gave that nurse to nurse report rather than having to call ahead first, that would expedite some of this communication and get the patient transferred faster. Telestroke consult conversation as the same as the transfer request. I've heard that some hospitals use certain telestroke consultation services that are not associated with any of the hospitals nearby. So that would, if that patient required transfer, then that primary stroke center would have to then call an accepting comprehensive stroke center too. So doubling the time on the phone. As far as transfer best practices, we could complete the handoffs, EMS handoffs, while transporting provider is en route. Drip and go, the same EMS crew from the inbound is the outbound crew too. And maybe the primary stroke centers might be better at choosing and calling an ambulance rather than the comprehensive one sending their team. So that's the list of potential best practices and the benchmark. Who knows what it's going to be at first? My guess would be probably around 90 minutes. And just as we've seen with the Target Stroke campaign, the Target STEMI, it'll eventually come down to probably 45 minutes. Who knows when exactly that's going to happen, but I'm excited to see when it does. And that's all I've got for you today. Happy to take any questions at all.
Thank you so much, Dr. Alunday. And if anyone has questions for Dr. Alunday, please feel free to place those in the chat at this time. And we have our first question, Dr. Alunday. What were the measures mentioned in the beginning of the presentation? Are you able to go back and share those again?
Oh, sure. These measures, patients no IV alteplase prior to transfer, elbow and MER eligible. That's
yes, those were the ones she was looking for.
Okay, great.
And Angela, you can find all of those in your Get With the Guidelines under your Get With the Guidelines Enhanced Measures drop down, as long as you have the primary stroke STK measures. We have another question. It says, are your nurses using VAN to rule out elbow?
That is a potential. I know a lot of centers are using that. We've instructed all of the ambulance crews around the area, actually throughout New Mexico, to use. Throughout New Mexico, we said, please use something. And there are a few different scales that people could use. VAN is one of them. LAMS is another. CSTAT's another one. I know some places use RACE, but those are all stroke severity scales. So we didn't take away FAST. That's still there. And what we've told our ambulances or our EMS crews throughout the state is, please continue to assess for stroke using FAST. If FAST positive, do you think they have a large vessel occlusion? And whatever your local department wants to use, please use that. In the city of Albuquerque, are the two main EMS agencies are Albuquerque Ambulance and Albuquerque Fire Rescue, and both of those groups are using LAMs, is what we're using. In-house in the hospital at UNM, we essentially just, we aren't teaching them LAMs up front. Just using, actually we're using BFAST in the hospital to try to catch some of those posterior circulation strokes. And if that's positive within the prior 24 hours, then we set off a stroke alert. We determine if they need a CT angiogram at the bedside. It's a little bit easier for us to do with the neurology residents that are coming down. We're a comprehensive stroke center. So we have high volumes of these patients, and it's a little bit easier. I want to say the expertise is a little bit better, but it really depends on the attending. But also in general, we're not limiting our CTAs to only LAMS positive or elbow screen positive patients. We're doing it for almost all strokes, pretty much because we're not afraid of the contrast that we're giving the patients. There's been many studies that show that the risk of contrast-induced nephropathy isn't really a big issue at all. And so it's also going to help out with their, even if they don't have a large vessel occlusion, it helps out with the screening for who needs a carotid endarterectomy, who's got intracranial atherosclerosis, and their risk for further strokes in the future. So no matter what, that information is helpful to us. And if we need it for thrombectomy, great, we get that information right away. If they don't have a large vessel occlusion, then still great, because it'll help our stroke neurologist figure out what we need to have the patient on to prevent their next stroke.
We have another question, and I believe it seems like maybe they're asking, you mentioned EMS calling the elbow scores ahead of time. I'm guessing that means just pre-alert that there's an elbow. And do you know if this determined the patient's destination? Did they choose comprehensive stroke centers based on the elbow score? And then have you found these field scores, I'm guessing the pre-hospital severe stroke scores, to correlate with elbow being detected in the hospital?
So from a state standpoint, we didn't dictate what the EMS agencies are supposed to do. We just asked them to obtain that information and report that information. If they want to do something with that, then great, to determine which hospital. Within the city, the 3 centers that take care of strokes, one of them is a comprehensive and the other 2 are primary, and we're all within in less than 5 minutes away from each other. So within the city of Albuquerque, those 2 agencies, AAS, Albuquerque Ambulance System, and Albuquerque Fire Rescue, both of those groups do have pre-hospital triage based on LAMS. So if it's LAMS positive, it's not like we're bypassing one hospital to get to another, because we're all so close together. So that's one of the ways that it's pretty well justified there. It's not like we're taking time away from Altaplace at one hospital and then being transferred to a comprehensive. We're not adding any extra time for that transfer. So just in order to get rid of the DIDO times within the city, we do have those triage protocols in the pre-hospital setting based on pre-hospital elbow scores. So yes, that we are doing that. And have we found those scores to be accurate? I could tell you we have not done a formal, what was their LAMS to, was it really positive? And that's because it's not as consistent as what we want it to be. A lot of times they'll know it and they won't tell it over the phone, so it's not documented. We don't have a great research infrastructure for looking at that as of right now. I will tell you that LAMS, CSAT, VANS, those studies have all been done multiple times with varying amounts of accuracy, but in general, they've all turned out pretty darn close to each other, with an area under the curve of about 80 or 0.8, which is a decent accuracy. It's definitely not the best, but it's not the worst either. And from my perspective, if you're able to catch a majority of the patients that have large vessel occlusions in the field and be able to transfer them to the appropriate hospital from the get-go, then I think you're winning there. Yeah, you're going to miss some, but you're going to miss all of them if you don't use that score in the pre-hospital setting.
I have one quick question for you. You mentioned that one of the best practices that's sort of being that's floated around is the idea that, you know, whichever agency is bringing the patient in would wait until that patient's started their drip, and then they would be the ones to take them out. In reality, I think that's probably a little more difficult than we would like. What sort of things would you foresee that would need to change from maybe like a legislative standpoint in order for that to become a reality?
I don't know if anything can change from a legislative standpoint. I feel like that's always in gridlock, but that's just a personal view of government on my part, I guess. But I have seen this work out pretty well. The former stroke coordinator over at one of our neighboring hospitals used to be a paramedic himself and was pretty high up within Albuquerque ambulance. So he knew all the paramedics that were coming in anyways to their shop. And he would be able to look at that patient and do his own LAMS assessment on those patients and go and tell his crew, the paramedics there, don't go anywhere. This one's probably going to get transferred. And many times he was right. And they would bring that patient directly over here. So it's totally possible. It just takes being able to figure it out quickly. You know, so if you're not able to have that initial gestalt when you see the patient, get that CTA immediately, you're not going to be able to make that happen. I will tell you at UNM, the paramedics drop off the patient, but they don't leave yet. They drop them off in the CT scanner, and we're getting that CT done right away. And more often than not, I'm showing them the CT scan. So we're looking at it together and we're going, oh, that one, here's the large vessel occlusion on this patient. We're gonna go for a thrombectomy. Or there's no large vessel occlusion, there's a bleed instead. Thanks for bringing this guy in. We're not doing a thrombectomy, but at least we can give him the right care. So I can say it's totally possible to make it happen. You just need to have the protocols in place to be able to figure it out quickly and have them not waste their time waiting around for us.
I'd be curious to know if there's any implications with regard to how they are reimbursed from third-party payers on how, if they're staying and not, I guess I don't know how that works, if they have to start like a new run or what that looks like. But anyway, it might be a conversation for another day.
That's a great question. I have no idea on that too. I would assume that it's two different runs, but I can't say that I've ever been a paramedic to know.
Yes. All right. Well, we are close to the end of the time. So if we have any last minute questions, please make sure we get those in for our wonderful speaker. Again, on behalf of the American Heart Association, my name is Allison Capetillo, and it's been a pleasure to have all of you today. We will be sending out slides and certificates within a week of today's presentation, as well as the recording. So I want to thank you all so much for your time and hope that you have a wonderful rest of your week.